solution that our organization developed to help improve counseling and care for children with disabilities. I do not have any relationships to disclose. I'll talk a little bit about disability data first. Some of you may be aware of the fact that 1.2 billion people in the world are living with a disability. That's 1 in 7, or 15% of our population. And yet they are often marginalized and underserved. This is even by development organizations, faith-based organizations, and government welfare programs. And across the world, in low and middle income countries, but also in many high income countries, the lack of services and care for these populations are connected to stigma related to the causes and treatments for disability. So many people believe that people with disabilities are cursed, that they may have contracted their disability through witchcraft or demons, or that their disability is the result of incest, contraception, and sin, and as a result that they're unworthy of their basic rights to health, education, and inclusion. As you can imagine, this has a huge impact on their health outcomes and their wellness. So you can see that there's very few children with disabilities enrolled in school, extremely high poverty rates, lack of access to health care. It affects employment and access to wash services. And then subgroups are also disproportionately affected. So women with disabilities, only 1% of the population of women with disabilities in the world are literate. And the mortality rates for children with disabilities are sometimes 4 times as high as the general population of children. And there are also significantly higher violence and sexual abuse for people with disabilities. So their needs are extreme, and they are represented, they are overrepresented in all vulnerable people groups, and yet drastically underserved. So our organization has been working hard to address this for the past 23 years. We started working in 1999. Our name is Kupenda, which is the Swahili word for love, and our partner in Kenya is Kuhenza, which is the Giriama word for love. And we've been working together in Kilifi, Kenya. That's where we test our solutions for children with disabilities, make sure that they're working, and then scale them internationally. We now have partners in 18 countries using our model. Our model is focused much more on the social model of disability, so looking at that stigma reduction and discrimination, as opposed to, for example, handing out wheelchairs. So our mission then is to transform harmful beliefs surrounding disability to those that improve children's lives. And one of the key ways that we do this is by engaging influential community leaders. So in Kenya, in Kilifi, where we work, 83% of the population is Christian, over 11% Muslim, and there's about, some studies say as high as 95% practice traditional medicine, so they will see their traditional healer in their community. So there's a lot of overlap, and these leaders have a huge influence on the way that the communities view disability. Their understanding of the causes, their attitudes towards people with disabilities, and the way that they treat them. So these key stakeholders are who we engage in one-day workshops. We educate them about the true medical causes of different disabilities and how to provide effective care and treatment, which is critical when we think about the pastors, many of whom are preaching that people with disabilities should pray and fast instead of seeking medical care, when traditional healers so frequently conduct exorcisms and give chants and ceremonies to remove disabilities. Many of these leaders are eager for knowledge to actually be able to help people with disabilities. And so what we see is a very high uptake rate after our trainings. We were funded from 2017 to 2019 to study this group of leaders to figure out what was happening after our workshops. And 70% of the participants were taking action. And in the first year after our training, they were reaching almost 5,000 community members with disability sensitization talks and outreach, and they were counseling and caring for almost 400 children with disabilities and improving their quality of life. So that was encouraging to see. And so in 2020, we wanted to do more tracking using an app, and we partnered with Boston University and with MIT to develop that app to help us see how these leaders were actually doing this outreach, how we could support them even more to improve their outreach. And we created this great app in a couple of months, and in February of 2020, we were ready to launch it, and then the pandemic happened. And we had to drastically change because the leaders weren't going into the community to give disability sensitization talks. They weren't visiting children at their homes to provide counseling and care. So we implemented a remote care model, or a model where they could go to the homes with PPE, but then the app became a tool to help us manage the caseloads that each leader had. And so it became our child case management app. And you can see here, this is kind of an earlier iteration, but there was a registration module. We then assigned the children to our NGO staff. The leaders would do counseling every twice a year with the children. At the time, we had a food relief delivery program. We did progress reports, and then a key component that I'll talk a little bit more about is our follow-up module, and we also had a way of tracking expenses. So this enabled us to track a lot more data around the children's needs and how we could serve them and follow up with them in a timely way. So the follow-up feature had a series of counseling guides. So our NGO staff would be counseling the children once a year. The local leaders would counsel them twice a year. But children who were showing signs of malnutrition or abuse, they were very ill, they were perhaps running out of medications, they had tailored follow-up built into the app. So the app would prompt the leader and the staff to do this follow-up. It would have a series of skip logic based on what the first interview had told them, so that they could, for example, do nutrition, medication, and stigma counseling in a very efficient way that was quite relevant to the child. It also was tracking outcomes for our programs and for individual children using validated tools such as the Washington Group measurements, activities of daily living, and Measure Evaluation's Child Status Index. So this is kind of the user journey through the app. You can see you register a child, you assign them to a staff. There's an intake which provides our baseline data, the local leader check-in, and the annual progress report, which all feeds into our follow-up counseling. Some children don't need any follow-up counseling. They're fine, they're stable, but many children do need regular follow-up, and the staff and leaders can indicate when that follow-up should happen. And they've provided a lot of feedback about the fact that being able to do that follow-up and keep all the contact information and the historical record of the child's case in the same place has allowed them to reach more children and more effectively. There's an emergency feature. So when we first launched it, we had emergency cases being fed into our NGO staff. So if a leader observed a child that may actually pass away in the next 24 hours because they were in such a dire situation, our NGO staff would be prompted, but over time we realized that the leaders themselves actually had the capacity to do that follow-up, and we encouraged them to do so by changing features in the app that would allow them to do the follow-up themselves, accompany the children to the medical facility in some cases, and then come back to the app to report the child's outcomes. At times, if the family's reluctant, we do still pull in our NGO staff to provide time-sensitive care. So the tool itself can be adapted for different organizations and different settings in and beyond Kenya. I'm going to show you some of the data that we have been able to collect through this tool. This is just, again, a sample of our data, and it's an example of what can be collected, but the tool can be tailored for different environments and organization needs. So the first thing we saw was that it tripled our reach. In the first 2 years, we were able to reach 3 times as many children as we had prior to using the tool. We then were able to look at the demographics of the children we were serving, what their needs were when they came into the program, and then was our program actually reaching those needs, serving those needs. So we looked at the wards. There are 35 wards in Kilifi County. We first realized about 20% of the children, we didn't know their wards, so we needed to go back and collect better data around that. But more importantly, there were about 14 wards where there were only a few children or even no children, so we could do tailored outreach to those areas based on what the app data showed us. We looked at the religion of the children we served, and we realized that there was a huge group of children who were Christians, families were Christians, so we wanted to do more pastor training for those communities. And at the same time, we realized that there were many Muslim children who perhaps were not being reached because only 3% of our population was Muslim, so we could run more Muslim trainings, Muslim leader trainings. We looked at the caregivers' livelihoods because in many cases that was connected to the wellness of the child. 91% of our caregivers were having environmental problems that were impacting their livelihoods. Kilifi is, There are many agricultural, the great majority of the people in Kilifi are agriculturalists or farmers, and so we looked at those environmental problems more closely, and we realized that many of them were experiencing drought or insects or poor soil that were affecting their family income, which allowed us to do tailored outreach to them around income generating support and advocacy and agricultural trainings to help those families improve their income. Of course, the app collects data on gender, but also allows us to compare it to Kilifi's gender division and to see that it was comparable to the county's male and female spread. We looked at the age of our beneficiaries to ensure that we were providing services that reached the groups that were most prevalent in our beneficiary base. And then we looked at the disability type and saw that most of the children in our programs had speech or sensory disabilities. What were their needs when they came into our program? Most needed access to school or medical assistance. There were other areas as well, but those were the areas that were showing the greatest need, and that allowed us to tailor programs to meet those needs. Were we meeting them? So fortunately, our data showed that we were doing well in counseling, in food access, and in school fees, as well as education. And the areas that we were perhaps doing less service provision was on target as well, because we were referring those families to other service providers rather than providing assistive devices ourselves, for example. We again look at this stigma and discrimination because that's the key component of our work, really looking at, again, the social model. And so when caregivers have accurate beliefs about the causes of their children's disabilities and the treatments for those disabilities, then we recognize that that has an impact on the care that they provide the child and the inclusion in both the home and the community. So over time, we could see that the parents and caregivers were showing more belief on the left side, which is the medical causes of their children's disabilities, sickness, problems at birth, genetics, whereas the community, that gray bar on the right side, remained believing that the children's disabilities were caused by demons, witchcraft, and genies. And this was after a year of working with the families, so this is a positive shift, whereas prior to that we were seeing more of the community influence on the families where they believed that their children's disabilities were related to the spiritual causes. And the children as well, are they experiencing increased wellness because of our programs? So we could see, again, this is just a sample, but the nutrition outcomes from baseline to our first annual report showed a 16% improvement in the number of children eating 3 meals a day, and the children who didn't always have 3 meals a day was reducing. Healthcare access was also improving, although there were fewer annual exams. Preventative care was increasing, so they were seeing doctors more frequently. They were able to access services and resources that they needed, and the number of children having no medical care dropped by 15%. We also looked at subsets of children. So this is a slide just about the hearing impaired children. Their caregivers' use of sign language, and we support this by connecting the parents and caregivers to sign language trainings. We give them resources around sign language acquisition, and we also provide some trainings ourselves. And as we could see, at intakes, there were no caregivers that were fluent in sign language, but at the annual report, 9% were. Sign language use, being able to help children meet their basic needs, had increased as well. And the caregivers who do not know any sign language had decreased by 20%. So we were seeing positive outcomes there. What's next for this tool? As I mentioned, it can be adapted for different settings and by different organizations. So we are partnering with more and more organizations seeking to make their programs more data-driven, community-led, and inclusive. We're scaling use in and beyond Kenya, and we're adding new GIS and mapping features to help us show where the children are living and in relation to the services and the leaders who have been trained to serve them. So I'm happy to answer questions at the end, and if you're interested in the tool, our website is there. We have it's an open source tool. There's a library of resources connected to our disability advocacy work and specifically this app as well. Thanks for your time.